Good afternoon, everyone. Thank you for giving me this opportunity. My name is Hemal. I'm an assistant professor of urology at University of Southern California. So these are my conflicts of interest. So I'm going to give you a general background about radical prostatectomy. It is the most common cancer in men in the United States, and radical prostatectomy remains the gold standard for localized prostate cancer. Approximately 40% of these men will undergo a radical prostatectomy. And again, post-prostatectomy incontinence remains the biggest source of patient distress and regret. Ultimately, with higher patient longevity, higher burden of geriatric patients, we're going to be doing more and more radical prostatectomies. And this has ultimately led to the evolution of multiple radical prostatectomy techniques. In some series, the rates of incontinence are as high as 21%, and rates of ED are as high as 70%. So there are certain patient factors that are non-modifiable that contribute towards post-prostatectomy incontinence, and then there are certain surgeon factors which has led to the development of certain techniques. Again, the anterior structures such as the puboprostatic ligament preservation, the detrusor apron preservation, AT preservation, and can help mitigate and facilitate early recovery of continence. So again, this has again led to the evolution of multiple types of surgical techniques. The Retsia sparing has excellent source of continence after surgery. However, the margin rates again are operator dependent, with some series showing margin rates of almost 40%, and the replicability of this technique also remains questionable. Again, in great hands, the margin rates are much lower. And ultimately, other techniques have been described, the multi-port hood technique by Dr. Tiwari, that levels the playing field, especially in his technique, preserving the anterior structures, mitigates incontinence and helps facilitate early recovery. So I'm going to be talking more about the single-port transvesical radical prostatectomy, which confers non-inferior oncologic outcomes as well as facilitates early return of continence. Just to give us a little bit of a background, we all have patients that have hostile abdomens. They've had previous abdominal surgeries and or pelvic surgeries, and ultimately this leads to adhesion formation that can increase the risk of bleeding, bowel injury, vascular injury, especially when going through a transperitoneal route. To help facilitate this, the single-port robot was developed by Da Vinci in 2018, specifically designed to work in small, narrow spaces, such as the extraperitoneal transvesical space as well as the retroperitoneal space. And again, with this technology, all the instruments of the robot are coming out from a 2.5 centimeter incision. Again, all the instruments are coming out allowing for efficient articulation. And again, this has ultimately led to the evolution of radical prostatectomy. Back in the day, the open retropubic approach was completely extraperitoneal. Now we're doing single-port extraperitoneal, single-port transvesical. And again, there's different approaches of doing the single-port radical prostatectomy. And again, I'm not going to go too much into the details of all. And I'm going to talk more about the single-port transvesical approach. Why is this important? Well, it allows to regionalize surgery to the extraperitoneal and transvesical space. What we know, these patients do really well. They have higher rates of same-day discharge, decreased postoperative pain scores, non-inferior oncologic outcomes when compared to the state-of-art, standard-of-care multi-port transperitoneal approach. Avoiding Trendelenburg in patients that have a hostile abdomen or that are obese or have COPD can be very helpful. Avoiding the peritoneal cavity, as we know, can decrease the risk of bowel injuries and ileus and things such as that. So again, the advantage of this approach is it marries the functional outcomes, which is facilitating earlier return of continence, with oncologic efficacy and regionalizing surgery to the extraperitoneal and transvesical space, especially in cases with a hostile abdomen. So with that in mind, I'm going to go through my case. I have a 74-year-old gentleman, PSF 7.2. Couple of Peyer's 5 lesions biopsied showed an unfavorable intermediate risk prostate cancer, negative metastatic workup, and this was his abdomen. So this was a gentleman, he was a Vietnam War veteran, had 2 gunshot wounds in his abdomen, had gone 2 X-labs, 1 ventral hernia repair, bowel resection, colostomy creation, and he was referred by an outside urologist to me for prostatectomy. Again, his IPSS score was 25, so again, radiation was not a great option in him. So we proceeded with a transvesical approach. Again, the extraperitoneal space in this guy was probably violated, so we opted to do transvesical. And the way we obtain our access is 2 finger breadths above the pubic symphysis. We make a 4-centimeter incision, go completely extraperitoneally, find the bladder, which is distended with saline, and then we put 4 stay sutures in the bladder, bring up the bladder up to the skin, and make a cystotomy. And the single port access kit is placed directly inside the patient's bladder, and the surgery is carried out. And again, there's no need for Trendelenburg. The arms are out in the patient. All the instruments are coming through that single incision, as you can see. We're using a floating dock technique. And this is, I'm going to go over the video. And again, the video is sped up a little bit, but as soon as you get in, you see the bladder, you're in the posterior bladder neck, you're identifying the retrotrigonal layer. It's the same layer that we come through when we were doing the posterior bladder neck. And we're going through the retrotrigonal layer, identifying the seminal vesicles and dissecting them out. So again, this is like the first step of the case. As we are dissecting, we'll be able to drop the rectum in the process, and we're carrying out the posterior dissection next. And the posterior dissection, again, can be carried out in an interfascial, intrafascial plane, depending on the patient's cancer and his overall. Finally, we then go to the anterior bladder neck. I like to go anterior first because I can identify the periprostatic fat, and that tells me that I'm outside the capsule of the prostate and I'm not going to the adenomectomy plane that we do for simple prostate. So it's very important to see that fat. And then all you have left is the neurovascular bundle dissection and the pedicle that has been ligated, and the bundle has been dissected off. And we use short bursts of bipolar energy using the fine Maryland to dissect the bundle off, and you can see the close relationships of all the structures here. And then finally, we carry out the anterior bladder neck. And in this guy, I chose to cut through the DVC, cold cut through it. Now, there is a risk of air embolism, so the pneumovesicum should not go beyond 10. And in this gentleman, since he had significant anterior disease, I chose to cold cut through the DVC. But in some cases, just like the Redsius approach, you can come underneath the DVC and completely avoid having to cut through these. So again, the urethra is now being dissected, and following that, the prostate will be removed out of the bowl, the single port access kit. We are ligating the DVC next. Now, one of the disadvantages for this approach is definitely not being able to do a good lymph node dissection. So again, I routinely don't do this for high-risk prostate cancer patients. I will routinely end up doing a multi-port approach or extraperitoneal single port and do a extended lymph node dissection based on the EAU guidelines. But in this guy, again, he was unfavorable intermediate risk, negative PSMA, so I felt pretty comfortable not doing nodes in him. And then following that, the anastomosis is carried out and in the standard circumferential fashion using V-lock sutures. So again, patient did great, negative margins were achieved. He was continent 4 weeks post-op. He was actually a truck driver, and he was able to. So again, just going over some of the other studies in a nutshell, this was a series out of Cleveland Clinic where all their cases were completed without any need for open conversion, bowel injuries, or blood transfusion. The transvesical approach was favored. And again, looking at the single port consortium, which USC is part of, the overall rates of positive margins with transvesical approach are approximately 18%. However, this technique definitely facilitates early return of continence, which is defined as no pads at 6 weeks, but overall no difference in long-term continence was noted. And again, if you look at the pathologic outcomes, the transvesical approach does not confer a high rate of positive margin when compared to multi-port radical prostatectomy. Because again, this is a cancer operation at the end of the day. However, the lymph node yield is definitely lower for the transvesical approach when compared to the multi-port approach. And again, comparing it to single-port extraperitoneal, transvesical approach has a faster return of continence. So again, this is not about cosmesis. This surgery is not about replacing the multi-port robot, but there are certain benefits to regionalizing surgery and avoiding the peritoneal cavity. Reducing length of stay, higher rates of same-day discharge, while contributing non-inferior oncologic outcomes, and especially in patients that cannot tolerate Trendelenburg or those with hostile abdomens, this approach may be beneficial. So with that, thank you so much. I'll take any questions, or we can answer questions at the end. Thank you very much again for this opportunity. Really appreciate it.
Right. Go ahead, Doctor.
Yeah, thank you. I think this approach seems to be simpler than the usual approach that we do. But the point is, can we do with the multi-port a transvesical prostatectomy?
Yeah, you can definitely do it. Yeah, go ahead.
Yeah.
Sorry.
Yeah, but the bladder capacity has to be a little quite optimum. If it is a smaller capacity bladder, probably you can't put all the ports through the bladder.
Right, right. I mean, I personally, I haven't done any with the multi-port. I know that Dr. Tiwari has published on this. He's done a few transvesical radical prostatectomies with the multi-port approach. But again, I don't have much experience with that in the multi-port arena, but I'm sure like with good bladder capacity, one would be able to.
So would you do this for only low-stage disease or even the higher stage where you think there may be some periprostatic extension or the neurovascular bundle is involved?
Absolutely. So that's a great question. So for high-risk disease, I try to avoid this approach mainly because I cannot do a good lymph node dissection. I'll do an extraperitoneal single port though in those patients. But to get back to your other question, if there's definitely if there's disease outside the prostate, again, I favor to do the extraperitoneal approach because I have more mobility. But in this patient, as you can see, his belly, his abdomen, frozen pelvis, I was like, well, I don't have any other option in him. So in certain patients like that, which is what a lot of my referrals sometimes are with these guys that have had X-slaps and the local urologist does not want to touch him, and so they'll all get these referrals, which is great for me, but then like, you know, we have to do these in a certain fashion.
You think it's easier than the usual extraperitoneal approach? It appears so that, yes, you can go easily.
Yeah. I don't think, I mean, there is a certain learning curve to it, and there have been several studies where they have looked at learning curves, but I do think that once you get past that initial learning curve, it's really hugging the prostate capsule, especially for favorable disease, favorable and low-risk prostate cancer. When you're hugging the capsule, you get a very nice outcomes, and these patients do great. They have great post-operative continence, which is where I see the most recovery.
Sajib, very good. We can take the rest of the questions after in the break. It's good to see you here. 15 years ago, I remember asking questions from your dad, of your dad. But now it's good to see you here on stage. And what percentage of your cases are single port versus multi-port?
So for me, I do mostly 80 to 90% of all my prostates are single port, about 10-15% multi-port, and then kidneys, it's half-half.
Fantastic. Okay, thank you very much.
A very good afternoon to everyone, and I thank the Vatikuti Foundation for this opportunity to present on techniques and outcomes of salvage robot-assisted radical prostatectomy. I'm Dr. Aditya Parikh. I currently work at Ahmedabad, and I'm presenting the work of, can you have the next slide, please? Of 3 superstar surgeons, 2 of whom are with us today, Prof. Senthil Nathan, Prof. PS, and Mr. Ashwin Sridhar. And I say superstar because achieving good outcomes in salvage prostatectomy requires not only good experience, excellent surgical skill, but the courage to not just face complications, but also to innovate and come up with ideas to prevent them in the future. Because UCLH is a big focal therapy center, we are also a very big salvage prostatectomy center. UCLH offers all kinds of focal therapies, and therefore HIFU was the one after which we have the most number of salvage prostatectomies, followed by radiotherapy and brachytherapy, which is the nastiest of them all. As you can see, the diagnostics are fairly inaccurate in this setting, with upstaging in close to 40% and an upgradation of the disease in about 20% of patients in both the focal and the whole gland treatment groups. Robotic surgery compared to open salvage prostatectomy significantly improves the continence outcomes as well as minimizes the complications, which are to the tune of about 8% in the perioperative period. Coming to the biochemical recurrence, there is a significant amount of biochemical recurrence, probably in a third of the patients following salvage prostatectomy when it is done after radiotherapy, whereas those numbers are fairly acceptable when it comes to post-focal salvage prostatectomy. The erectile function of most patients is likely doomed, whether it is after whole gland treatment or after focal therapy. But continence significantly is better when it is after focal therapy and we have to do a salvage prostatectomy, close to 88% at 2 years and 72% after radiotherapy at the end of 2 years. This number of 203 has now crossed the 300 mark, and it is only growing as time comes. So what are we doing to improve the continence outcomes in the whole gland treatment? One of the things that we have come up with is the omentoplasty technique, which has not only brought down the time to catheter removal, it has decreased the leak at cystogram, and it has significantly improved the continence outcomes at the 3-month interval. Can we play this video, please? So after salvage, after radiotherapy, the endopelvic fascia is white. The prostate is stuck everywhere, including being stuck to the rectum. Can we play that video, please? So the previous one? This one. This is a video. I think you should be able to play it from there. Yeah. Thank you. We also find the rectum fairly stuck to the prostate even in HIFU cases. So the key points are that very careful lateral dissection must be carried out at the beginning of the procedure, and very slow and meticulous posterior dissection must be carried out. In the HIFU setting, the recommendation is to start laterally, do the pedicles first, and then proceed towards the midline where the prostate is likely to be stuck. This is the same recommendation that can be given in the radiotherapy setting. This is a video as well. There was one slide. Yeah. In the post-brachytherapy setting, there is significant amount of apical fibrosis. There's a high risk of positive margin. Can we please go back and play the video? Yeah, thank you. There's a high risk of positive margin at the apex. In brachytherapy, they don't put seeds in the midline to avoid damage to the urethra, and therefore dissection should begin in the midline and then proceed laterally. We often find these brachytherapy seeds in the midline or towards the lateral sides. In the post-nanoknife, post-TURP setting, the prostate, again, this is a video. The prostate is irregular shaped, and there are fairly asymmetrical prostate lobes. One has to be very, very careful with the traction that is applied. We also have one solitary cased post-TULSA, in which, as this is a post-TURP case, where very careful bladder neck dissection must be carried out and very gentle traction must be given. This is the post-TULSA case, in which, because the treatment was transurethral, the entire anterior prostate was missing, and this was a Retzius case. So as we proceeded anteriorly, there was practically no anterior prostate on the side where the treatment had been administered. This is again a video. We do certain maneuvers to improve the outcomes. One is a preoperative enema. We use a bladder retraction stitch, which gives us an additional robotic arm to play with. We have also started using the endoclose device to lift the prostate up. Long-staying anastomotic sutures, a Roberts catheter with 2 eyes, one below and above, an omentoplasty technique that we spoke about, where the transverse colon omentum is thinned out, brought down to the pelvis, and wrapped around the anastomosis. This improves the vascularity and the continence outcome. In the RCS sparing setting, this peritoneal flap is taken right before we start the prostatectomy. And after the prostate is out, this peritoneal flap is taken down and the rectum is covered with it. This gives good vascularity to the site of the anastomosis. So the key take-home points are that post-HIFU, one must begin lateral, start to come medial later. In the radiotherapy setting, very careful posterior dissection, and one is likely to find fused endopelvic fascia. In the brachy and the cryotherapy setting, very careful apical dissection, often starting in the midline in the brachytherapy setting works well. And in post-TURP and nanoknife setting, very gentle traction and an expectation of irregular prostate lobes is very important. The technique must be adapted to the primary modality of treatment, and that is the key to safe surgery and good outcome. Thank you very much.
Very good. Excellent volumes. Now, you've presented salvage after so many modalities of treatment. Which one is the most easiest or the most difficult to do salvage? Another thing I saw was certain cases you've done in a RCS sparing manner. What percentage of cases would you do RCS, and why would you choose RCS?
I think the decision between RCS and the anterior approach is largely surgeon preference. And again, as Prof. PS had spoken before, when there is anterior T3 disease that is expected, we avoid the RCS sparing approach. So it is a fairly equal volume of RCS versus anterior in today's times at UCLH, but a large percentage of these cases have been done as anterior cases, as anterior prostatectomy cases. And the first question, sorry, if you could repeat.
Which one is difficult? After which primary modality is surgery difficult?
So the difficulty is again very individualized to how the treatment has affected the prostate. We have found very, very bad adhesions even in the post-cryotherapy setting. But the worst outcomes are after brachytherapy, which is because the prostate is often very, very badly stuck at the apex. And therefore, the continence outcomes are the worst after brachytherapy.
I was under the impression that proton's the worst. I'm going to ask PS to weigh in on this.
Anand, I wasn't listening to what you asked, sorry. I have to repeat it.
Which is the most difficult to do after which therapy is the most?
So I think you asked also about RCS. So for salvage, of course, RCS is the same as for primary. So if you're going to do it in a primary case RCS, i.e. the non-anterior T3 tumours, you can do the same in a salvage setting. In terms of what's most difficult, I don't know what Mr. Nathan thinks, but I would say, again, the brachytherapy cases and the Tulsa case was also very challenging because you've got no planes there and a lot of fibrosis. So the brachytherapy cases, the external beam radiotherapy cases also can be very challenging because, of course, you've got a lead pipe urethra, and so there's a much higher chance of leakage, and which is why Mr. Nathan developed the amenoplasty technique to actually help that and to stop stricturing. So I think brachytherapy, external beam radiotherapy, Tulsa are the worst modalities. The easiest tend to be the HIFU cases. Usually they just have a bit of rectal tethering. Sometimes, you know, the HIFU is delivered on the left, but you have what looks like HIFU effect on the right. So, you know, the general principle, I think, with a primary case is you go from one step, you finish one step, you go to the next step, and then you finish that step, you go to the next step. But with a salvage case, I think the principles are that you don't do that. You go from where it's not stuck to where it's stuck. So you move around a lot, you mobilize where it's not stuck, and that then makes the area that it's stuck much easier to then mobilize.
Good afternoon. It's a great pleasure being here. At the outset, I would like to thank the foundation for the fine invite. I would also love to acknowledge the presence of my mentor, Professor Saklani, in the hall. He's been the driving force for surgical journey so far. My talk is focused on robotic incisionless supralevator posterior exenteration. The key steps of this procedure is identifying and standardizing the surgical steps such that complex steps have been broken down into simple, reproducible, and which can be performed safely. A word about fluorescence-guided lymphatic mapping, predominantly for clearing aberrant lymph nodes, which are not included in the template of a complete mesocolic excision. And a word about need for splenic flexure mobilization. The entire gamut is focused on natural orifice specimen extraction and total intracorporal anastomosis, thereby avoiding the utility incision and the sequels of utility incision, which could be a surgical site infections or late incisional hernias. It's a 66-year-old lady who's gotten a tumor 2 centimeters above anal verge, locally advanced, stage T3 node positive, anterior CRM positive, in view of loss of fat planes with the cervix. She's completed conventional neoadjuvant chemoradiotherapy, and again, restaging MRI shows a residual disease with a loss of fat planes with the cervix. Anteriorly, she's been planned for a Supralevator posterior exenteration by virtue of anterior CRM being positive. That's a 6-port configuration technique what we regularly follow, and a layout about how the ICG has been instilled for a tumor tattooing just to map out the lymphatic system in the real time. So what we essentially do is for all low third rectal primaries, we do an proctoscopy and an ICG installation, and we can identify the aberrant nodes as well as that of the lymphatic channels in the real time. Our approach has always been an IMV first submesocolic approach. We are conventional routine believers of splenic flexure mobilization than selective splenic flexure mobilization. So we tent up the IMV, work below the IMV, carry forward the dissection in a medial to lateral fashion up till the lateral abdominal wall is being reached. An attempt is made to divide the splenic flexure ligaments medially, that is pancreatocolic and splenocolic. Once we define the ventral surface of a pancreas, we follow the ventral surface of pancreas, we divide the ligaments, make an entry into the lesser sac. That completes the procedure in the upper abdomen. After that, the focus shifts towards the lower abdominal part where the sigmoid colon is lifted up by arm 4, right pararectal fold is scored. A sigmoid is mobilized in a medial to lateral fashion craniocaudally, and the dissection carries forward in the presacral TME plane. We switch to the firefly mode, identify the lymphatic trunks, which is evident here, and work around caudocranially along the superior rectal artery and inferior mesenteric artery. Conventional complete mesocolic excision ensures that all the lymph nodal packets are taken care, but as in this case, which can be appreciated here, there are certain nodes which are lying beyond the defined template. So we recorrect our course and we start harvesting these nodes. These nodes are station 16B2. They are between the inferior mesenteric artery to the bifurcation of the aorta. So we have been clearing them. So we individually divide the lymphatic system so that there's no postoperative lymphoria, or even if it is to a bare minimum. And we do an en-bloc excision of station 253, which extends from origin of the IMA to the origin of the left colic artery. That's inferior mesenteric artery, which has been skeletonized. IMA is high ligation is being performed. And that's the area of 253 and station 16B2, which has been completely cleared. We further carry forward the dissection in a medial to lateral fashion, and then go on to the lateral line of told incised, communicate both the spaces, medial and lateral. That's the last of the splenic flexure ligament, that is a gastrocolic ligament, which has been divided. Pelvic component, we have grouped it into 5 sectors. One is on a posterior. We carry forward the dissection caudally as much as possible. Then we switch our focus towards bilateral anterolateral, and then into the anterior and come back again to the deep posterior. This patient was planned for a type 1 extrafacial hysterectomy. So we have divided the bilateral tubes, ovaries, and the round ligament. And uterine vessels are being clipped and divided. Bladder is being mobilized off the rectum by getting into the space of utrovesical, vesicocervical, and vesicovaginal fascia. Circumferential colpotomy is done over an uterine manipulator, and the dissection carries forward in the rectovaginal septum, making sure that the entire vagina is being reflected off the rectum until the bare area of the rectum is being encountered. So that's a dissection along the left lateral part of the pelvis. So once it has been circumferentially mobilized, the last part is the deep pelvis. We get to the pelvic floor, divide the hiatal ligament, take the dissection through the hiatal ligament into the puborectalis sling. We staple divide this and hold up the inferior mesenteric artery, harvest the intermediate nodes, carry forward this dissection till the proximal conolic division point. An enterotomy is made. Animal is delivered through the wound protector, which is placed transvaginally. It is brought out through the side of the proximal colon at a desired length. Endoloop is a good potential substitute for a purse string. So we have used it to secure the enterotomy. So once the proximal colon is been divided, the specimen is completely extracted through the transvaginal route or an wound protector. The proximal colonic bowel is again rechecked. And we complete an double staple coloanal anastomosis with a contour CDH28. Patient was complaint enough for all the elements of ERAS protocol. She was discharged on day 6. And that's a histopathology specimen. She had an T3N2 disease. So we went back and we looked at our data. We had a propensity-based matching of historical controls where we had not tattooed and prospective patients where we had tattooed, and the single parameter or the single factor which came out positive is N2 disease. The chance of having an aberrant lymph nodal disease which is positive was much more common when there was an N2 disease. Thank you for your attention.
Very nice presentation. Any questions from the floor, please?
So using a lot of ICG, right?
Yeah.
So do we have that maximum dose of ICG which can be used for one particular surgery? That is 0.1 to 0.5 milligram per kg. So do you actually see that the maximum dose is not crossed? Yeah.
Yeah, it's within the prescribed limits. 5 ml per kg body weight is the lethal dose. But 5 ml per kg body weight is...
0.1 to 0.5.
No, lethal dose.
Lethal dose.
Lethal dose is, so we never cross that limit. I keep saying it is more safer than a paracetamol.
Right. Thank you very much.
Thank you.